we see we have made clearly progress over the past 14 years in the treatment of metastatic colorectal cancer with a couple of, let's say, general ideas. One, we have introduced different agents. Today we have cytotoxics, the fluoropyrimidines, aromatic and oxaliplatin. We have introduced over the past years bevacizumab, and then also the anti-EGFR targeted antibodies, cetuximab and panitumab. And then this year we have now positive data for Aflibercept and Regorafenib, and we expect that these drugs will also be approved in the future. So the panel of different drugs is increasing. On top of that, we have validated the biomarker, at least a predictive biomarker for KRAS mutant patients, saying that KRAS mutant patients do not benefit, with a few exceptions always, from cetuximab or panitumab. So we have learned a lot on the molecular biology, on the targets, and we are starting to learn aspects on the markers. And second, what is important also is the multimodal approach. 15 years ago, we rarely did resection of liver metastasis. Today, it is a way to cure some patients. Resecting liver metastasis or lung metastasis, if we can obtain a complete resection, we can cure some patients. And on top of that, we have learned more the strategy that if we have patients with initially not resectable metastasis, liver metastasis for instance, if we can give them one of the better chemotherapy cocktails in combination with the biological targeted agent, that we can downsize some of the metastasis from initially not resectable to resectable, so that we can cure some patients. We can convert these metastases from not resectable disease to resectable. So that evolution and strategic thinking and multidisciplinary approach, multimodal approach, has changed completely over the last 15 years. We see several important developments in GI cancer. A general theme is the multidisciplinary approach, that it's clear that if we can go for expert centers and expertise, and then link that to multidisciplinarity, that's better for the patient outcome in general. There are several of the sessions where there is a focus on the aspects of chemotherapy, surgery, radiotherapy, sequential treatment strategies, combining the different treatment options. So that's the first important theme. A second important theme is the development of molecular markers, where we see that there are more and more data coming through that molecular markers are crucial and are important and will be more and more important. Many of them still need further validation, but our knowledge is clearly increasing. The example of KRAS is well known in colorectal cancer as a predictive marker for lack of activity for anti-EGFR targeted antibodies. But also in gastric cancer, we see an increasing knowledge. For instance, what was known already was the HER2 story, that HER2 is an important target for antibodies for trastuzumab in gastric cancer. But also, for instance, at this meeting there was a lot of discussion on c-Met as an important target for as well gastric cancer as hepatocellular carcinoma. We know that 40 to 50% of gastric cancers express MET on immunohistochemistry. And we have at least phase 2 data that the inhibition of this, or targeting the MET receptor with antibodies may lead to activity in patients with gastric cancer. And the same was seen in hepatocellular carcinoma. We've seen several new studies. Most of them were phase 2 studies. And then there was a discussion on the emerging phase 3 data that will come through in the near future in pancreatic cancer. Because metastatic pancreatic cancer is a very bad disease. Most patients will die very fast, unfortunately. But there's now expectations that there may be some changes. We have seen already the data on FOLFIRINOX. And what we see is that FOLFIRINOX is, at least in patients in very good condition, in a selected group of patients, is becoming a reference treatment in these patients. But that means also that the bar is becoming higher and that we will see some other data. For instance, the Abraxane data may be reported soon. There was some discussion on the potential role of SPARC here, on the potential role of HENT as a predictive marker for gemcitabine in pancreatic cancer. – 2012 was a year where there were important data on angiogenesis. We have seen 3 sets of data this year that are important, and we see some new updates also at this meeting on these agents. First of all, the concept of continuation with bevacizumab in second line after progression on bevacizumab plus a chemotherapy backbone. What we see is that the TML trial, as it is called, is a pivotal proof of concept study that shows that in second line patients continuing bevacizumab after progression on first line, that in this situation, after continuing bevacizumab and just switching the chemotherapy, that these patients have a better outcome. I will present the data at this meeting for the first time on that this is regardless of KRAS status, that this was true as well in KRAS mutant as in KRAS wild type patients. The progression-free survival was prolonged with this post-progression continuation concept and strategy in KRAS wild type and mutant patients. Second drug is Aflibercept. The first data of Aflibercept were presented last year at the same ESMO GI meeting here in Barcelona, and we now have more robust data of Aflibercept in second line, also showing that 1/3 of the patients were pre-treated with bevacizumab, and then also in this group of patients pre-treated in first line with bevacizumab, in second line the continuation of or the change to Aflibercept improves the outcome. So that's an important data set also regarding angiogenesis. The correct study is a study that evaluates the activity of Regorafenib. Regorafenib, that is an oral multi-tyrosine kinase inhibitor targeting different targets. And we did a randomized study in patients failing all different treatment options, failing the classic cytotoxics, fluoropyrimidines, irinotecan, and oxaliplatin, as well as bevacizumab and the anti-EGFR targeted antibodies in KRAS wild type patients. We did a study in last line, Regorafenib versus placebo, 2-to-1 randomization, and we have shown that the survival as well as the progression-free survival was clearly prolonged with Regorafenib compared to placebo. And this is an important study because this is a patient population where there is an unmet need. We don't have other treatment options in these patients, and with this drug we can improve the survival as well as the progression-free survival. The reactions were that it's very interesting that there is an unmet need for patients in this situation. That's an important reaction. Of course, we don't cure patients, and the difference, although statistically significant different, and although also clinically relevant, remains modest. But you have to realize that this is a very difficult situation. These patients failing all different treatment options, and that's why many of the colleagues are happy that this drug will be taken forward. Of course, we have to learn, and it's clear that not all patients do benefit from Regorafenib. If you look at the progression-free survival curves, at the initial 6 weeks, the first 6 weeks, in the placebo and the Regorafenib arm, they are together, and then they start separating. If we see a curve like that, that means that there is probably a marker so that we can select which patients do benefit and which patients do not benefit. And that's going to be important, that we do enormous efforts, and that's also what the colleagues want, that we do efforts to try to find out which patients do not benefit, or positively which patients do benefit in this setting. And we have started with the Biomarker program also for Regorafenib to find that out. Regorafenib is an interesting drug because also at the last ASCO meeting there were some interesting data presented of a third-line trial. Patients with GIST, gastrointestinal stromal tumors, failing imatinib and sunitinib, and in third line there was a randomization, Regorafenib versus placebo, and they've shown also that the trial met the endpoint, primary endpoint, which was the progression-free survival. And there was an important difference of the progression-free survival in these in patients with GIST. So this year, 2012, we have seen two interesting and important phase 3 trials showing the activity and confirming the activity of Regorafenib in chemorefractory metastatic colorectal cancer and in third line GIST tumors. Another important study that was presented for the first time at this meeting is a randomized phase 3 study from the PETAC group, which is a pan-European group on trials in adjuvant colon cancer. And we did a study, a large study in more than 2,000 patients, stage 3 colon cancer. We randomized the patients with FOLFOX or cetuximab, and we enriched the population for KRAS wild-type patients. The results were presented here at this meeting for the first time, and have shown that there was no benefit of adding cetuximab to FOLFOX in stage 3 colon cancer patients. We don't have an explanation why this is, but the data are quite robust and are consistent data that are presented here. The interesting discussion point is why is the effect of cetuximab in KRAS wild-type patients when combined with FOLFOX different in stage 3, such as the adjuvant PETAC-8 study that is being presented here, compared to stage 4, to patients with metastatic disease. Nobody has a good explanation. Several hypotheses are brought forward and are being discussed also here at the meeting, but the data are quite robust and consistent as they are being presented here for the first time.